Hello everyone and welcome back to this respiratory therapy update session. I'm delighted to introduce the next speakers, again frontline clinical workers, and also have been beavering away in the background on guidelines, research and God knows what else. So delighted to introduce Dr. David McWilliams. He's been a real support to me and many over this pandemic and continues to be, and he's going to talk about proning for awake and ventilated COVID-19 patients. Over to you, David.
Thanks, Rachel. So like Rachel said, I'm going to talk about proning and kind of my experiences and some general approaches to proning. And I've got to say that it's something that I had some experience of going into this pandemic, and probably I've seen more patients in the last 9 months than I'd seen in the rest of my career. So it's certainly something we're seeing a lot. And I think for those of you that are out working clinically or have been redeployed into areas, it's probably something that you've generally been coming across. So just to begin with, on this session, I want to try and set a bit of a scene. So I know you've had some really good sessions this morning talking about pathophysiology, ARDS and ventilation, various different factors. But I want to do a very quick recap just on ventilation and perfusion and why that's so important for proning. A quick slide just around the impact of ARDS. Then we're going to talk about proning and the actual process of getting a patient into prone, and then some of the complications, precautions and impact for us as physiotherapists. So in terms of ventilation and perfusion, I think to start with, we're going to consider this when we think of the humble slinky. So for those of you that aren't familiar with slinkies, they're these weird spring type things that are supposed to walk downstairs, but always get stuck about halfway along. But they look like this little picture just down at the bottom. And why this is important is if you hold a slinky from the top, it's not uniform how it distributes itself. So what happens is the entire weight of the slinky is acting on the top segments. And as you go down, there's less and less weight applied. So what this means is you have quite big gapping and opening sections at the top and everything kind of mushed together down at the bottom. And when we consider the lungs, something very similar actually happens. When somebody's in an upright position, you get the entire weight of the lung acting on the upper sections, which stretches open those alveoli and those airways. And you get this kind of closing down and squashing together a little bit at the bottom. So when we consider gas exchange, what actually happens is as somebody takes a spontaneous breath, well, the airways at the top are almost nearly fully open. So there's quite a small amount of change that occurs and quite a low level of gas exchange that's occurring up there. But in these segments, they're all a little bit mushed together down in those dependent regions. Because they're already quite closed, there's quite a big potential for change, which draws more air down into the bases. So you get this bigger degree of gas exchange down at the bottom, very gravity dependent. Now, when we consider perfusion, there's a similar kind of process that happens. So first off, we know pulmonary vascular resistance is very low. And firstly, that's because we have such a vast array of pulmonary capillaries that cover almost the entire surface of the lungs and the alveoli. And you can see that highlighted quite nicely here in this picture. So what that means is there's quite a low pressure coming out, but as well, because blood is a fluid, it's going to be very dependent on the impacts of gravity. So when we look at things like perfusion scans, what we find again, although the blood leaves the heart going towards all different sections of the lung, gravity is playing a part, so more preferentially will go to those lower regions. If somebody's upright, for example, if somebody's lying on their back, it'll be going posteriorly rather than anteriorly. So there's a bias towards gravity dependent regions. And what this means again for ventilation and perfusion is, well, we need air and blood to be in the same place at the same time for gas exchange to occur. And in those patients who are spontaneously breathing, both perfusion and ventilation increase as you move from the apices right down to the bases. So it's the wonder of the human body. It doesn't matter what position we get ourselves into, whether we're standing on our head, lying on our sides, lying on our back, gravity will always create dependent regions. So the gas exchange is going to the bottom, the blood is going to the bottom, and we have a perfect VQ match. Now, the problem comes when we put people onto ventilators and we start trying to take over their breathing and breathing for them. We go back to our previous analogy with the slinky. So we know the airways at the top are already stretched out a little bit open. There's a little bit of air already in there, and those at the bottom are squashed down. Now, if we consider when we're trying to blow up a balloon, particularly if it's one of those long sausagey party type balloons, when they're completely flat, that first breath is actually quite difficult to get that airway to work or to get that balloon to open up. Whereas when a balloon's half inflated, it's a lot easier. So when we put a patient onto a ventilator and we're pushing positive pressure into that airway, what will actually happen is those upper zones will inflate even more with quite small amounts of change down at the bottom. So you have a complete reversal of the normal system in a spontaneous person. So increased airflow now in those apical regions that are already slightly open, and a reduction in the amount of air entry down at the bases. And that's important because we know, well, the blood flow isn't going to change. It's still going to be affected by gravity. So blood's still going to be going down to these lower areas. And if anything, now because we've introduced a positive pressure in the top part of this person's chest, that's going to restrict blood flow and push even more down. So as soon as we put somebody onto a ventilator, even a healthy individual, we're creating a VQ mismatch. So we get perfusion being directed to those dependent regions, ventilation now being directed to the apical regions, and a VQ mismatch occurs. Now, when we add in ARDS or ARDS type presentations, as with our COVID-19 patients, we'll start by just considering normal lung anatomy. So this is a normal alveoli, and what we have is a nice single-celled wall of the alveoli. We have a very small interstitial space, and then we have a single-walled capillary. So what happens is our oxygen molecule will come through. It's got to go across one cell, very small swim, one more cell for the eager red blood cell that's waiting to take it up, binds the hemoglobin, and off it goes around the body. Now, the two other important factors to consider within this alveoli are the type 2 cells, and they're secreting something called surfactant. Now, surfactant has two real purposes. The first one is it provides some degree of lubrication within that airway. But also, because that airway is so thin, just a single cell, the addition of a fluid layer will now give it some stability and some structure, and it just prevents it collapsing down on itself. But probably for ARDS, the most important component to consider here is this little macrophage. Now, I like to think of this little macrophage as being a bit of a sentry. He's a bit like a ninja. So he's waiting there for something to come in. Any foreign invaders, anything that it doesn't recognize, it's going to attack, it's going to try and prevent any infection occurring, and it's going to call for reinforcements. Now, what happens with ARDS is something sends this little ninja a little bit haywire. And what happens is our macrophage now starts attacking anything that moves, causes quite significant damage to that alveolar wall. Now, the call for reinforcements brings in this protein-rich inflammatory fluid, and that brings more macrophages, more leukocytes, fills this airway with fluid. It also puts fluid into that interstitial space. It damages the capillary itself. And with any sort of inflammatory process, you'll get those clotting factors coming in. So now our poor oxygen molecule is coming in. It's got to swim through all of this exudate. It's got to get across quite a thickened membrane. And that's it too, if it's even got a red blood cell waiting for it at the other side. So you start to see why there's such challenges with gas exchange in the ARDS type inflamed lungs. Now, the best way I can kind of think about this, because this isn't a uniform process, this doesn't affect the entire lung in the same way. And the best way to think about ARDS is like a wet sponge. So if we have a sponge, we dip it in a bucket, we pick it up from the top, we'll get three distinct sections really. So you've got the bottom area of the lung or the sponge, which is going to be completely full of fluid. It's completely saturated. There's no air going in there. Gravity dependent. You'll have the middle regions, which will certainly still have some fluid present, but there'll also be some elements of air within the sponge. And then at the top, all the fluid has rushed down to the bottom. So this is generally air filled. And this is what happens within the lung. You'll get three distinct sections. One is this completely saturated, full of fluid, inflamed. You get the middle area, which has kind of a mixture of air and fluid, and you get this relatively healthy lung at the top, which is often termed the baby lung. So when we put this into perspective, and I know you've looked at some scans and things before, this is a CT scan of a healthy chest. And for those of you that haven't looked at CTs before, imagine we're now stood at the foot end of the bed looking at our patient. This is the right lung, this is the left, and we're gradually taking slices coming down towards ourselves. What you can see, heart in the middle, you've got the capillaries and the blood vessels coming out, which are the white areas, and you have the dark areas, which is air, and you have this nice combination. When we get somebody who's got an ARDS type presentation, we get our wet sponge approach. So you now get these completely saturated areas down at the bottom of the lung. You get the middle sections with this combination of fluid and air, and you get some degrees or some areas of normal air entry. Now, the problem is, because this isn't uniform, and it would probably be simpler if the lung did just behave like this. So you have the lower lobes that are saturated, the middle lobes that are okay, and the apical sections, which are relatively healthy. But this impacts quite heterogeneously across the entire lung. So this is the lobes, the segments, down to an alveolar level. So in essence, we're now trying to ventilate very damaged lungs, but we're also trying to ventilate three different types of lung tissue in the same patient at the same time. So it becomes quite challenging. And it's unsurprising that a lot of our patients then go into quite severe respiratory failure and need an escalating level of support. So when we consider prone positioning and the effectiveness of prone, and this has been advocated more and more in recent years. We've had some quite positive studies showing improvements in survival from prone positioning in those most severe ARDS cases. And the typical kind of recommendations are those people that have quite poor gas exchange despite high levels of ventilatory support, using factors such as the PF ratios, so the amount of oxygen getting into the blood dependent on the amount of oxygen that we're providing. And certainly those patients that are starting to require 60% or more oxygen on the ventilator to maintain target saturations and PO2 levels, we're starting to think we're getting to a more critical stage. And particularly if we're then needing higher levels of PEEP, higher levels of plateau pressures, driving pressures to kind of open the airways, we need to be more lung protective. So prone positioning itself, well, why does it work? Well, first off, this is a lateral chest X-ray. I don't think I've ever clinically looked at one of these in practice, but I know some centres would have done, maybe more so in the past. I love a CT really. But what this shows quite nicely is the lungs are actually quite a lot bigger posteriorly than they are anteriorly. So as we come onto this section, you can see posteriorly across the back wall, you have a much greater surface area of the lung than you do in the anterior part of the chest. Now, associated with that bigger surface area for gas exchange, you also then have a better blood supply, partly because of the size of the lung and the size of the area, but also depending on your theories around evolution, from back when we were monkeys or crawling around on all fours, there was a preferential supply of blood to the posterior aspects of our chest wall. So we've got a bigger surface area for gas exchange, we've got a better blood supply. Now, the other thing we need to consider within the chest, there's another big organ, and that's your heart. Now, what tends to happen is your heart, when you're this critically unwell, is working quite hard, tends to be full of fluid, and it's resting quite nicely on your left base, compressing, reducing any air entry and gas exchange from occurring down there. On the bottom picture, what you can see is as we flip somebody onto their front, the heart now rests on the sternum. That frees up the base to start to open up a little bit more, and we can start to utilize these larger posterior surface areas. Now we go back to the VQ and our little balloons we were talking about before. The ventilator, first of all, the weight of gravity is going to start stretching open these posterior areas now because they're at the top. And the ventilator is preferentially going to be trying to force air into those partially opened airways, which is going to further enhance and utilize that network of airways and blood supply. So we're starting to really maximize VQ. And the other thing is turning somebody onto their front is a very useful position to help in drainage of secretions as well. So we've got a bigger surface area of the lung, we've got a better blood supply, we take the heart out of the equation and rest it on the sternum, and we can help to drain secretion. So the prone position itself, the recommendations are we should be starting this early. And I think prone has a mixed kind of reputation, probably less so in the last year or so now with the pandemic. Certainly in centres I've worked in the past, it's gone a bit out of vogue. Some centres seem to use it quite liberally, others don't really seem to use it at all. And I think one of the problems with some of these measures are they're a little bit more complicated. They take more members of staff. If you're not familiar, there's concerns around how to actually complete the procedure. And therefore they get retained as what we'd term a rescue therapy. So you tend to have patients who have come in, increasing levels of ventilatory support, increasing levels of oxygen support, still not improving, getting to quite a critical stage, and then they're flipped over into a prone position. Now, at that point, the outcome may become self-fulfilling. You're choosing the sickest patients heading towards end of life and trying to turn them onto their front. Maybe it doesn't work, and then, well, it's not effective. So certainly the recommendations, the evidence suggests if you're doing this, you should do it early, recognize those patients with significant lung disease, turn them over, utilize that extra lung area, and protect the lung tissue from them early stages. Should be used definitely in combination with lung protective ventilation. So here we're talking 6 mils per kilo based on ideal body weight. And the other thing is when you turn them, leave them there for a while. So minimum recommendation is they should be doing it 16 hours at each time, and then going back into supine for a rest to then go back into prone. But often this will require deep sedation and paralysis. Patient's going to be, it's not the most comfortable position, certainly to be left in for 16 hours. I think there's already been some talk around the COVID-19 patients needing more sedation anyway. Certainly we've seen a lot of ventilator asynchrony, a lot of agitation needing quite high levels of sedation or often paralysis. The analysis we did in wave 1 in the patients that came through QE when I was there, we kind of found that about 90% of the patients were paralysed, and that was generally for the first week, just to get on top of their management. And around 2/3 of them were proned on quite regular occasions. So this was something we're using very often with the COVID patients. So the procedure itself, a lot of this comes into the preparation. So you need to ensure you've got an adequate number of staff. I think there's a lot of conversations at the minute about, it's not just about beds, it's not just about ventilators, it's about actually having trained staff available. then suddenly suggesting we need to find a minimum of 5 to perform proning becomes a bit of a challenge. I think what a lot of centres did, and the centres I've certainly worked in, is creation of proning teams. Often, I think with a high BMI associated with COVID-19, that ended up being 7 people. But you'd have 1 at the head end and then 3 on either side. You definitely need an airway trained person in that bed space to manage any emergencies. Usually that's one of the doctors who takes the head end. But as long as there's an airway trained person in the bed space, that's the most important thing. Make sure that airway is secure and there's a difficult airway trolley available. You want to be able to respond quickly to any emergencies. Generally pop the patient on 100% prior to turning, and make sure you can know where all the lines are. You don't want to get halfway through the maneuver and realize there's an arc line wrapped around somebody's arm, there's a catheter on the wrong side of the bed. So there'll be quite a lot of time of just planning the area, looking along the entire bed and making sure you can see everything that's there and what you're going to be doing. And then obviously stop the NG feed and aspirate just to empty the stomach. You don't want to be causing any aspiration. The technique I'm going to describe is called patient wrapping. Sometimes people call it the Cornish pasty. This is certainly one that's recommended by the ICS, but I know different units have different policies. So I would say wherever you work, find your local proning procedure. If you are involved, be reassured that there are very qualified and trained people in that bed space, and they will talk you through everything that you do. And they do that every single time. So don't feel you're going to be thrown into a situation where you're suddenly proning patients and don't really know, or you're worried about how that's going to go. You'll be very well supported. The patient wrapping procedure, so tend to place pillows over the chest, the pelvis and the knees. A clean sheet is then placed across the top of the patient, but obviously you leave the head and neck exposed so you can keep an eye on the airway, keep an eye on the patient and see what's actually happening. And then the sheets, the 2 sheets, the one underneath and the one on top, are rolled together to create this like past the edge effect. The patient, the whole maneuver is led by the person at the head end and the person with the airway, which makes sense. It's anything like a log roll, really. The patient slid across to one side, gradually raised up. The 2 sides then gradually swap their hands one at a time, and then the patient's lowered back down onto their back. The safety checks immediately, we need to make sure the ET tube's not kinked. Flipping somebody over, you can cause malpositioning or migration of the ET tubes. That needs to be monitored quite closely. And then you reattach all your monitoring, make sure that patient's stable, resuming infusions, and make sure there's nothing wrapped over, they're not lying on top of anything, for example. Now, potential complications, the most commonly cited complication is pressure sores. Patients either lying on lines, lots of pressure going through the face, for example, through the bony prominences. But another common one is ET tube blockage or kinking or excess secretions. I'm going to come on to this and the impact for physiotherapy in a minute. You can see quite a lot of facial edema. If you've not seen this before, when your patients have been prone for 16 hours and their first turn back, they can have very swollen faces, particularly around the eyes. It can be quite distressing, just to be aware that that will happen. You can obviously disconnect any lines. So what they tend to try and do is disconnect as much as possible and as much as safe to do before the maneuver. You can get cardiovascular instability. Tended to see that more on patients when they've returned from prone back to supine due to issues with oxygenation and gas exchange. Another commonly cited one has been brachial plexus injury. There was a really good study published this week from a group of physios in QE in Birmingham, and they found a rate of between 10 to 15% of not just shoulder injury, but actually nerve damage as a result of proning. Now, whether this is to do with the sheer number of patients that were being proned, the acuity of illness, whether it was there were certain patients who were so unstable they had to stay in prone for quite long periods of time. There were patients that couldn't be repositioned even when they were on the front because they were so unstable, I'm sure was a contributing factor. But also I think the lack of available space, the lack of available staff probably had an impact. So going into wave 2, I think this is something as best we can with the resources we have, we need to be mindful of and try and make sure we're protecting shoulders as much as possible. And also staff injury. But if we follow protocols and we're well trained and everyone talks through things safely, hopefully this can be avoided. In terms of care of the prone patient, pressure care is massive. I said that was one of the biggest complications that we see. You'll often see patients placed in the swimmer's position, where one of the arms is up and head's turned to one side. They should then be repositioned every 2 to 4 hours. That again takes a minimum of 3 people to achieve. It's important for maintaining, again, shoulder range of movement, trying to reduce pressure. The pillows underneath can reduce the pressure on the chest, the abdomen and the knees. And what you'll tend to see is the whole bed goes into a reverse Trendelenburg position. So it's tilted to 20 to 30 degrees. And that will just take away some of the impact on gravity on the face. and can certainly prevent some of the swelling that you might see when the beds are completely flat. In terms of chest care, as I mentioned before, so often these patients are deeply sedated and paralysed. I know Vicky did an excellent session before looking at the impact of these patients with possible quite copious secretions, no cough effort, high pressures going into the airway, going to make things very difficult to clear, and certainly things won't be clearing by suction alone, even if it is a good drainage position. There tends to be quite a high risk of secretion retention. I think this was the first time we really became aware of the secretions being an issue. When we first started receiving COVID patients in the first wave, the reports were often that these would have dry chests, very minimal physiotherapy input, maybe you should be in a proning team, that sort of thing. And then the first few patients after a couple of days were being changed from prone back into supine, blocking their ET, desaturating quite quickly, either needing bronchoscopy, return to prone, or quite poor outcomes. So we became very aware that these patients had quite excessive secretions, often quite thick. They're paralysed, they're not coughing, they're there, they need accessing. If they are dry non-predictive chests initially, we still recommend that you should try and suction at least once per shift just to make sure the airway is clear and assess. But as I say, chest physiotherapy is often indicated. I think one of the other challenges I talked about proning in the past is, one, it's been used as a rescue therapy. And I think sometimes people are nervous about approaching those patients. They're prone, they're sick, they're unstable, and need to be hands off. Actually, what we're finding with COVID, and what you'll probably find, is because the gas exchange is so much better, it's probably the most stable that patient's going to be when you're treating them. You can still do everything that you would normally do, just in a modified way. So we would often, or we would always, if they had secretions, treat these patients with 2 therapists or with 2 pairs of hands, one to be doing manual techniques and then a form of assisted cough, whilst the other one is performing suction. Now, in terms of assisted cough, the real aim here was to maximize peak expiratory flow. So that's a rib cage compression, either bilaterally or on one side. At times we had people using their forearms to put a compression at the peak of inspiration through expiration to try and get some expiratory flow. Often quite liberal use of saline as well. Saline we would instill with the bed at 30 degrees and then treat with the patient flat, or maybe with a slight bias towards head down. And we found that quite useful for this group of patients. Obviously, positioning from side to side is quite difficult, and I won't go over other techniques. I know Vicky's covered these in the previous talk. The other thing we did find, though, was physiotherapy itself was actually quite useful just prior to supination, whether that was immediately or in the half an hour before. The patient's stable, they've generally been stable for a few hours. Try and give them a good clear in that position before they're then flipped over. Often that makes supination more successful. And also, if you're in and around the bed space when they are supines, you can then try and treat again if you have mobilized any secretions through that change in position. So awake proning was probably something that I'd never come across before, and then started to get increasingly advocated during wave 1. And the theory being that, well, we've done this with patients who are ventilated and it's very, very effective. This could be beneficial if we use it earlier in those people whilst they're still spontaneously breathing. Again, we know it can improve oxygenation. It might therefore reduce the need for mechanical ventilation. And if we can stop people needing ventilation, hopefully we're going to reduce mortality or secondary complications. In terms of practical aspects, when you look at the Intensive Care Society guidelines, they really do advocate starting this quite early. So anyone with confirmed or suspected COVID-19 requiring 28% or more oxygen to achieve target SATs. Yes, it does escalate to those people on high flow nasal oxygen, CPAP or NIV, but actually even somebody on 28% or more may benefit from a prone position. The guidelines are available from the Intensive Care Society website. And in fact, if you put COVID-19 proning into Google, it's one of the first things that come up. So it's easily findable. Turning somebody into prone is generally easier, as the patient can help you, or they can roll themselves over if they've got the reserve and the ability to do so. But as with anything, when patients can join in, it can be a positive and a negative, because awake patients that can help are also awake patients that can complain. And a lot of patients might find this uncomfortable. As we move on to the next slide, you'll see within the guideline, there are some suggestions around positional changes, which suggest mainly around 30 minutes to 2 hours in each position. So lying prone on the right, sitting up on the left, prone again, and continually repeating the cycle. So you wouldn't take somebody who's spontaneously breathing and awake and try and leave them on their front for 16 hours. It's not going to be comfortable. They're not going to thank you for it. You need to ensure you've still got close monitoring throughout. And I think probably one of the biggest challenges here and one of the biggest contentions comes in, and I know there's been lots of discussions around this, is I think in the first wave, we probably accept that we intubated maybe too many people, or we intubated people too early. We've maybe underutilized things like CPAP and high flow nasal oxygen, which could have potentially prevented some people from needing ventilation. I think in the second wave, we're going the other way. I think now we're using these modalities a lot more. And the argument then becomes, are we doing this for too long? And actually, should we be intubating certain people earlier? And I think awake proning fits into this side. So it definitely seems to be having an impact. And the anecdotal evidence is it is improving oxygenation and potentially avoiding intubation in certain patients. But we don't want to go too far where it's purely serving to delay intubation and the need. So you need to have a very clear criteria for what constitutes failure and what is the escalation plan. And I think that's the most important aspect of this. And that probably goes for CPAP, NIV and high flow as well. But also consider the potential for the patient to desaturate when they return to supine and how you're going to manage that. As I said, there's the guideline that's available. I've waffled on enough now, so hopefully there's some time left for questions. But I think prone positioning has been widely used in severe cases of COVID-19. I've certainly, as I said, seen it more in the last 9 months than I'd seen proning in my entire career. It can result in quite significant and very rapid improvement in gas exchange and oxygenation. And hopefully I've started to describe some of the mechanisms of why that occurs. It requires a skilled team and excellent communication. Complications are common, but can be prevented with care and attention to detail. And anecdotally, awake proning does seem to be having a positive effect, but just remember it needs that clear plan for escalation and decision making around where to go next. Thank you very much. I'm happy to try and answer any questions, and my details are on this slide as well if we don't get time and anyone wants to get in touch directly.
Wow. So I've got questions coming from all over us, David. That was a brilliant presentation, thank you. First one, in the UK, who initiates the proning discussion, or is it part of a team?
I think it would be unit dependent, and I think it would depend on the culture of that unit. I think some areas may be very medically led, and I think a lot of units, though, have got very robust MDT approaches to talk about patients and acute management. I would like to think it would be multi-professional in most units. I think a lot of the positives that come out of COVID is we now have very robust multidisciplinary protocols and standard operating procedures for a lot of things, including proning. I think it's having that robust and consistent approach which is important.
Thank you. Assessment of brachial plexus and early injuries. Do you recommend it? How do you do it? That's probably in a very short period of time, please.
One of the things that we found very useful, which was by luck rather than judgment, is a lot of our outpatient staff are redeployed into critical care. I'm not suddenly going to become an expert in assessing a brachial plexus. I think there are certain aspects around positioning, but I think linking with your shoulder specialist, you don't have to become a shoulder specialist yourself overnight. Linking with your OTs, linking with your physiotherapists, develop protocols for positioning, limb care and education more than anything. Yeah,
so there is a team, I think it's at the Royal Hospital, maybe Stanmore, I don't want to make that up, Queen Square. There's definitely London Hospital looking into this, and they're looking into people who have got brachial plexus injuries post-proning in ICU, because we are seeing some neuropathies that aren't related to proning as well, and they're looking at positioning when they were in ICU, etc. So watch this space for sure. Now, I'm just going back. Compliance with prone, if they're going to tolerate it, do they tolerate it straight away? Do you have to ride the storm a bit, or once you turn them, do you know?
I think one of the big things I found with the COVID patients is that actually they don't seem to tolerate very much. And whether it's a slight change in position at times, whether it's moving an ankle, they would could desaturate for quite a long period of time. I think you might not know immediately, but within an hour or two of whether they settle. A lot of them do. I think it's more a case of patients that just don't respond. So rather than it making them worse, they just don't get any better. And I think once you've identified that they're non-responders, it's looking at other adjuncts and other methods.
And what's maybe different in the COVID patient where proning has been had a good response, or sometimes an incredible response, and you turn back supine and then they quickly de-recruit or the oxygen requirements go up, we know that carryover effect is significant. And we've never really seen this, certainly in my career, where we would be reproning as a therapeutic intervention, even though all the evidence says not to use it as rescue. That's generally what we did in the UK before COVID. So yeah, and I think that's multifactorial. Like you said, it's a physiology that Bridge talked about this morning. It's the secretions, the COVID pneumonias and the superimposed pneumonias, and then it's everything you've just talked about as well, with how this virus affects the lungs, and why, from a VQ perspective, why proning should work, why it's almost nonsensical.
Yeah.
Last question on saline.
Yeah.
Favorite subject. So when you install saline, we're both a big fan of saline installation for secretion clearance with the right patient, with the right technique. You install the saline. How long do you leave it when you're doing your manual techniques before you would suction? And is there any adverse effects of doing that?
So what I would say, and I've seen different use of saline. So I instill it, and the idea is to instill to then shake it around in somebody's chest to try and loosen secretions. We know it's not going to magically make secretions loose themselves, but you're shaking low viscosity fluid around. It's then anecdotal, so it's dependent on the patient themselves. Sometimes you'll put it in, shake, and you'll feel secretions moving straight away. Other times you'll need to do a few cycles of 4 to 6 kind of bibs with expiratory compression to try and see things moving. I think anybody that asks me about the dangers, the negative impact of putting saline down, I'd ask them to go and watch a bronchoscopy, because the amount of saline that's put into somebody's chest compared to what comes back out is nowhere near what we're doing. So I think when it's used appropriately and targeted for the right patients, it's very, very effective, but it's not something we should be using liberally without indication.
Completely agree. Well, thank you so much for your time, David. David is on Twitter as well, and he's very kindly put his email up for a lot of people to see, so I'm so grateful. Thanks, David. And Sam, I'm going to welcome you on our next speaker. And Jake, thank you so much. Stanmore do have a brilliant guideline for brachial plexus, preventing brachial plexus injuries and picking them up, so thanks for that. So Sam, I am going to welcome you on. And if you wouldn't mind sharing your screen, that would be fantastic. So Sam has helped me out before very, very kindly. And I'm so grateful for her to be here today to talk about rehab. That's correct, isn't it? Acute rehabilitation in COVID.
1 minute. Just go here. How's that?
Brilliant. Thank you. Off you go.
Okay, great. Wow, what a presentation to follow. Great. So I'm Sam. I'm a physiotherapist working in critical care at Barts Health, and I have the pleasure today to talk to you about acute rehabilitation in COVID. Now, the way I've done it today is that we're going to work through a clinical scenario to kind of highlight some of the challenges that we're facing at the moment with doing rehab in ITU during the pandemic. So first of all, I just want to get you to have a little think about the components of rehabilitation. And we're not just thinking about mobilization, exercise. Rehabilitation encompasses multiple components. And when we're thinking about this, we want to think as early as possible. So some people earlier already touched on the fact that a lot of our patients were sedated and paralyzed for continuously for a couple of weeks. And our normal sedation practices would be to encourage daily sedation holds, as we know that this can have an impact later on in recovery. So thinking as early in that point and kind of thinking about challenging those. Pain management, again, equally very important as part of rehabilitation. So making sure that our patients are not in pain and it's well controlled so we can facilitate that rehab. Already touched a bit on mobilization. Speech and swallow, naturally, really important as part of the recovery process. Speech, so not just allowing our patients to be able to communicate with us as staff members, but also with their families. And thinking about swallowing, so that assessment of when our patients will be appropriate for commencing swallow trials so that they can start to eat and recover. Functional rehab, so thinking much more about probably the daily activities that you and I take for granted, like brushing our hair, brushing our teeth, and starting to normalize those routines as part of the recovery. Delirium management, again, really important. Thinking about our non-pharmacological management of delirium, so day and night cycles, trying to allow natural light to come into the room, daily orientation charts, communicating with our patients is all going to help towards that recovery. And along with that, psychology, again, a huge part of this in terms of rehabilitation. So not only are our patients, in ITU and having to deal with something that could be potentially very traumatic. Obviously, patients all deal with it in different ways. But the fact that a lot of patients will wake up in ITU and, they've got Darth Vader at their bed space trying to speak to them with a respirator on, it can be very disorientating and confusing. And what we can do as therapists and people that are involved with the patients is start to stimulate those conversations, do you find that you're having night terrors? Are you having hallucinations? Actually, this is very normal and quite a common complaint in ITU. Thinking about environment, so obviously ICU has its challenges alone and equally on the ward, and it's not a normal environment, so trying to normalize that and humanize the ICU. Family, again, a really key part of the recovery and also a real challenge during these times. So making use of your inquiry hubs, getting patient video calls and contact as much as they can is also going to help to contribute. And then when we're thinking a little bit later down the line with sort of principles of training, so exercise and strength and endurance to continue hopefully that positive trajectory. So I wanted to talk a little bit through a clinical scenario, and we're going to kind of go through it in terms of asking these questions about, when do we know when is the right time to recover? So it can kind of just get a bit of a method and a process in your mind when you're coming to ITU. And this might be, hopefully some things are familiar and then if not, then they're new. So first part, when is the right time? So when do we know when a patient is appropriate to commence rehabilitation in critical care? So let's say you're due to see this patient today. You've had a really good read of the notes. They've been in ITU for a couple of weeks. They got admitted with COVID. Their past medical history is high blood pressure and diabetes. So think about just like a typical scenario. So we're going to look at our systems assessment or an A to E assessment. And again, as long as you're doing a comprehensive assessment, it doesn't really matter which you choose to use. So this is a scenario here. So airway, we've got a tracheostomy patient. Breathing, they're on a pressure support ventilation, so we know that they're triggering their own breaths. They're on quite a bit of support. Saturation is 95% on 50% of oxygen. Again, a fair amount, which is quite common. Cardiovascularly wise, they're quite stable, but they're on a little bit of NORAD. Now I say a little bit of NORAD because I know the strength and doses that we use in our ITU, so it would be good to familiarize yourself with what doses and parameters that you use in your ITU when thinking about your inotropes and your vasopressors. And what would be really good to find out is this NORAD new? Is this weaning? Why are they having this? In terms of disability, so our patient is alert. And again, this is just a scenario. The patient may not be so alert, but in terms of their Glasgow Coma Scale, they are E4, so their eyes are open. VT, they've got a tracking, they're not trying to communicate at this point, and M6, so they're following some commands, but they're not able to do a CAM ICU. For those of you that are not familiar, CAM ICU is a confusion assessment method where we ask the patient several questions and get them to squeeze our hand in response to identifying letters. And again, can just give us an indication as to whether the patient is delirious or not. But our patient can't do this because they are so weak. In terms of E, we're thinking about our attachments. So catheter, a bowel management system, Artline, CVC. We know that we're on a ventilator, being fed through an NG tube, and we have some infusions. Great, so you've had a little look at the chart and you've had a good read of the history of the notes. So now we have a nurse at the bed space. Great. So we have a chat with the nurse. So we say, hi, I'm Sam. I'm one of the physios. I'm here to come see this patient. And says, oh, hi, I'm Fran. And I say, oh, is there anything that, I need to know about this patient? Like, have they been stable when you've rolled them or we sat them up in bed? And poor Fran has just come on shift and doesn't know this patient and also has 3 other patients to look after. And unfortunately, this is quite a common scenario. So you say, okay, Fran, not to worry. So as you can't get this information from Fran, what you might want to consider is doing an on-the-bed assessment. So looking at range of movement or rolling in bed and sitting up in bed to see how hemodynamically stable the patient is and how they respond from a respiratory perspective. So obviously prior to doing this, you're going to have a chat with the patient and say, hi, I'm Sam, I'm one of the physios, we're looking after you today. Are you happy we just do a little bit of movement in bed and hopefully that, if the patient responds, great. It's sometimes they might not be responsive, but we're still going to have that clear communication, explain what we're going to do at this point. And then I've just put at the bottom there, if you're unsure, always discuss with a senior physio. So nobody's ever going to be mad at you if you're unsure whether a patient is safe to mobilize. And as long as you kind of go with an explanation and your thoughts behind these things, people are always going to be happy to have a chat through with that. Great, okay. And I just wanted to highlight this. So Carol Hodgson and Powles did an expert consensus on recommendations for safety criteria for mobilizing our ventilated patients in ITU. And this is a really good document if you want to just start to familiarize yourself with, the safety criteria. So they use a traffic light system where green is you're good to go. And they also separate it into in-bed exercises and out-of-bed exercises. So green is good to go, yellow is proceed with caution or just to be aware, and red is kind of a bit of a hard stop, is like we wouldn't mobilize in this scenario. So it would be good to familiarize yourself with this document. One thing I'd just like to say, though, is that each ITU is different and will have different parameters and different things done. So again, good to have a baseline, and then you can also have a chat with the team about what your unit does. Okay, great. So we've had a look at the patient. We know the history. We're happy from kind of an objective point of view that we're good to go. Now we need to think about how we're going to do this. So hopefully some of you are familiar with the tile assessment. So our task is basically, this is the first time this patient is going to sit on the edge of the bed. They've been pretty unwell. They've recently had a trachea. They've, done ICU acquired weakness. We know that the nurse can't help because she's looking after other people. So in terms of individual, you've recruited 2 other pals to come and help you. Now, what's important here is thinking about skill mix. So because of this particular patient, if we were 3 redeployed physios who normally work in MSK, this would not be appropriate to carry on with rehab as it wouldn't be safe. We need somebody who is going to at least be experienced in ICU to look after the trachea, and because our patient is on some cardiovascular support. So our loaders are severely weak patient. They have a normal BMI, and I've mentioned about the trachea and the support already. And the environment. So intensive care has its challenges already as an environment, and then equally we're also thinking about lines and attachments and floor space, especially if you potentially expanded your ITU into maybe theatre space. You need to make sure and plan that you have all the equipment that you need ready to go, things like slide sheets. And for PPE, so I use one of the respirators and I have to shout to be able to hear myself. So again, it's just factoring all these things into consideration before you undertake your intervention. And we're still going to have a chat with Fran. So we're going to say, Fran, we are going to sit this patient on the edge of the bed. We're quite happy that we've got somebody that can maintain the airway. Fran says, that's fine. I'm just going to be next door. So if you need anything, do shout. But we're just making sure that that chain of communication is clear at all times. Right, so what do we need to do now? Again, we've done our assessments. We've done our risk assessment. We've had a little look at the patient. Now we need an actual plan. So this is our plan. And in an ideal world, you'd have this discussion, I guess, away from this bed space, just to be like, okay, I'm going to lead on this. It's my patient. We're going to go this side of the bed. We're going to move all the infusions over to the other side. This person's going to do this, this, and this before you get to the bed space again, so that you're going in with a confident plan. So Susie's our senior ICU physio. She's happy to look after the trachea. We've got John. He's a redeployed band 6 MSK physio. John, you're going to climb on the bed behind the patient to help with trunk and head control. And me, and I'm going to be in front. And we know Fran is going to be in the bed space next door, but we've asked Fran before she leaves, any chance you'd be happy to pause the feed and the insulin and disconnect anything that doesn't need to be connected this time. Great. If you are unfamiliar with the environment, really key to locate your emergency alarm. Nobody's ever going to be upset with you if you pull the emergency alarm and they arrive and everything's fine. They probably might be a bit upset if you don't pull the alarm and they arrive too late. And make sure that your slide sheets are ready. Great, okay, so we know our patient is appropriate. We know that we've done the risk assessment to make sure we are ready to go. Now we're going to actually do the intervention. So not just COVID patients, but every patient who has been in ITU will have an individual recovery trajectory. So that basically needs an individualized approach. So we're looking for aiming at fully informed consent by explaining to the patient reasons why we're doing this. And again, as I was just reiterating earlier about communication being really key. And if any issues arise, you're going to stop and ensure that they're safe at all time. So this plan is for this patient, so it's individualized. So we sit the patient on the edge of the bed, and what happens is their saturations drop. This is, again, in my experience, quite common. and it can take some time to recover. So you have a couple of options in terms of you give the time to recover. By that, I mean, if they don't start to come back up imminently, then you're going to be giving your boost of oxygen. And if you have somebody who is familiar with the ventilator, you can think about increasing the pressure support, if potentially having a bit of air hunger and might need a little bit more support with that. But just to be aware, it seems to be quite a common theme with our COVID patients. The same as patients that are on the ward, sometimes even just rolling in bed, and they can desaturate rapidly. So this is our actual intervention. We sat our patient for 4 minutes. She had no sitting balance. She required head and trunk control. We did a little bit of passive range of movement while sitting, just to see if we can get some activation in limbs. And we found that naturally she fatigued very quickly. And again, this is a very common scenario, especially for first time sort of sitting on the edge of the bed when the patient has been in ITU for quite a few weeks. Okay, so we've done our intervention. Now we need to think about how we're going to progress this intervention. What is the next steps from here? So things that we really need to consider when we're making like a plan with our patient is the fact that these patients in particular are very densely weak. So the recovery time is going to be slow. This was our patient's first sit on the edge of the bed, and what would be really key to find out is what happens after we get them back to bed for the rest of that day, the evening, to see how they are the next day. You might find that actually they've kind of fallen in a bit of a heap. They needed more support from the ventilator. Perhaps they needed more cardiovascular support. So actually maybe it was a little bit early. Or they might have been absolutely fine, and then you know you're quite happy to proceed. That will just help to indicate your plan for the next few days. And obviously for this patient, they have a tracheostomy, so we need to be considering our ventilation and tracheostomy wings as well. So we have found that particularly with our weak patients, that alternating days of wean and rehab, with the view of helping to encourage that physical function recovery alongside a respiratory sort of muscle power recovery, following sort of the same trajectory. And also because our patients are incredibly weak, doing lots is not necessarily beneficial. We also want to maybe think about when we're planning our rehab that depending on how our patient managed the first time, actually whether they need a little bit of support from the ventilator. I know that people have during today have spoken about sort of increased oxygen support, same with ventilator settings. Can we support them a little bit more so they can do a bit of rehab and then come to weaning on an alternate day? And then we still want to be monitoring for assessment for speech and swallow. So our short-term plan is we've measured our patient for a tilt and space chair and a hoist sling. So we know that they need supported sitting. Potentially to consider hoist the next day if we have staffing capacity and the patient is stable enough to do so after the intervention that we did today. We know that our patient fatigues very quickly, and we know also that they have a BMS in. So as per our protocol, they're only allowed to sit for maximum 1 hour with that anyway, but you might want to start looking at about 30 minutes and increasing that time. Ongoing assessment for appropriateness for weaning. And again, thinking about your alternate days of wean and rehab. And then because of the patient has a tracheostomy, thinking about planning for cuff down and PMV trial. However, so during our first wave, we didn't put the cuff down and PMV in line whilst they were on the ventilator. I always know this is very aerosolizing generating procedure. However, that's something that you might want to risk assess at the time and discuss with your team, which needs to be an MDT approach. And in the short term, we're continuing with sitting on the edge of the bed to aim to improve sitting balance. And just a key point here is that more is not always better. And to have a comparison, if you're somebody that wanted to increase your bench press, you wouldn't all of a sudden start bench pressing 3 times a day in the gym. It will be too much. You'll be at risk of injury as a healthy individual, and it's not necessarily going to be beneficial for your recovery. So doing more for our patients in this time may not necessarily be the best option. Thinking a little bit longer term in rehabilitation, again, reflecting back to that sort of multifactorial aspect of rehab, orientation charts, so using your magic charts on the wall if you don't have the space because you've expanded into a different part of ITU or you just don't have the walls. Daily orientation with speaking with the patient and asking, seeing if the nurses can also orientate the patient. Encouraging natural light in your sleep routine and working alongside the MDT. Thinking about goal setting. So we want to empower the patient as much as possible and get them involved with their goal setting as much as we can. Using our outcome measures. So we use CPACs and ICU mobility, again, to assess recovery. thinking about humanizing the ICU and involving family as much as possible. Obviously, as I mentioned earlier, during these times, it's really difficult, but we do tend to set up video calls with our families to get them involved in the rehab, as it's really reassuring for the patient who's working with everybody in PPE, who doesn't know anybody, doesn't recognize anybody. So it just offers that little bit of extra support. We think about a stepwise progression of sitting balance. So initially we're thinking about challenging outside of that base of support for sitting. And as we start to improve that, thinking more about your functional rehab. So again, these daily routines that, that we do without even thinking about. So brushing your hair and brushing your teeth, involving your occupational therapist where possible. And then once sitting balance achieved, moving on to like your standing hoist equipment. So getting your patient weight bearing, stepping without foot plates. For those a little bit more advanced, your SARA steadies and relator frames. And again, your patient may also step down before some of these things are happening. So depending on their trajectory. Great, so now we've talked about how we will progress and what we're going to consider, and then what are the next steps. So as I mentioned, it's possible that some of the patients might be stepped down a little bit earlier than usual to free up ITU beds, but are likely to still have ongoing complex needs. Now, you'll be doing your assessments all the way through, and as once your patients start to become a little bit more alert and engaging, you can start to do your more like neuro assessments, where you can start to identify any irregularities or complaints. As mentioned earlier by David, sort of like your shoulder brachial plexus injuries. We're also seeing some peripheral nerve injuries. And as Rachel mentioned, this might not necessarily come from proning. We're also very aware of the thromboembolic events that happen within COVID. So making sure that you're doing your comprehensive assessments will ensure that you're going to pick up on these things to help to manage them early on. Those on the ward, so whether your patient has been on ICU and stepped down to the ward, or they've just been on the ward and just been managed there, are still presenting with similar complaints. So fatigue remains a big issue, and breathlessness. So thinking about targeting your large muscle groups to combat fatigue, things like pacing, and again, your slow rehab is going to help to help with the recovery. Breathlessness management, so finding out the underlying causes to why your patient might be breathless. So is this because they are not getting enough oxygen in the blood, and actually do they need some more support from oxygen adjuncts? Do they have an underlying respiratory condition? So do they have COPD or asthma, and would they benefit from bronchodilators? Or are they anxious and actually will need some anxiety management, and thinking about your positions of ease. A lot of our patients on the ward still have ongoing oxygen requirements, and again, it's thinking about when is it appropriate to wean these. And I mentioned already about your full comprehensive assessment to identify sort of peripheral or central injuries going on there. And then hopefully, as that recovery trajectory continues, you want to think about your training principles, so your progressive strength and endurance exercises. And again, it's the same principle of a stepwise approach of something that's individualized to your patient and their needs. And then thinking about your discharge planning. So I think that's the next talk, actually. So to summarize, I'm not doing too bad for time. Rehabilitation is multifactorial, and we're going to try to work as an MDT as much as possible, not just thinking about mobilization and exercise, but family, speech and language, normal daily routines, non-pharmacological management of delirium. Thinking about your risk assessments, this includes for the patient, the scenario, thinking about your skill mix of your therapist and whether it's appropriate to do rehab today or not, but also thinking about yourself and others. If you are the person that is behind every patient who is densely weak throughout the day, you're going to burn out. So you need to look after each other, communicate with each other, and support each other. And communication is key. I cannot stress this enough. Get to know your work colleagues, get to know your consultants for the day, get to know your nurse in charge and the nurse that's looking after the patient, and just communicate with everybody at every stage. Comprehensive assessment of your patient is going to help to identify any early complications or any residual problems from ICU and help to manage those early on. Individualized plan, not one size fits all. And this applies to all ITU patients. This is not just COVID. Yes, we have some densely weak COVID patients, but we also have some densely weak just critical care patients. So doing your comprehensive assessment and identifying goals that are appropriate for your patient and their needs. Slow recovery, so pacing your rehabilitation. We as therapists are potentially a little bit guilty of wanting to do everything we can for this patient, but sometimes rest is the most important thing. So again, just thinking about your patient as an individual. Consider your alternate wean and rehab days. Again, that's to facilitate that positive trajectory of, respiratory muscle power improvement and physical function. And again, just to reiterate that more is not always better. I've just put some resources together there if people want to have a little look. And yeah, I finished with 5 minutes to go. Thank you very much.
Thank you, Sam. Another fabulous presentation. So there is there's a few questions in the chat, a couple of which I will bring to you. So a great question about GCS. So is low GCS a contraindication for rehab, so in the critical care environment? What is the lowest safe score we start to think about?
Okay, good question. So I think it's thinking about the reason why they have a low GCS. So if you don't know why, then and it's new and it's worth flagging. Personally, if our patient, so a lot of our patients who have been on, quite a few concoctions of paralyzing agents and sedation and sedatives, are a little bit low to RAS. That wouldn't mean that I wouldn't sit them on the edge of the bed, as long as I have done my risk assessment, because actually you can stimulate more activity and the patient may become more alert on the edge of the bed. However, if there's been a sudden drop in their GCS, then that's definitely something to escalate pretty quickly. Or if perhaps they've had like a new neurological event that may, have then, I guess the similar scenario, drop their GCS. But as long as they're things to consider are, we usually think about a GCS of 9 for protecting your own airway. So as long as if our patient has a trachea or a tube in and they're then obviously less of a concern, but if they don't and then they drop their GCS again below 9, then we are looking to escalate that.
Yeah, certainly from my time working in neurotrauma, rehab will often improve the GCS or the alertness / orientation of a patient because it's doing something very functional. So like Sam said, it's very much understanding the reasons why. There's just some comments that I'm just going to highlight in the chat about ICU diaries being really useful for patients. Sometimes relatives might not be keen on them other patients and vice versa. The jury's out on diaries. I mean, I've used them since stage art. I think they're an incredible resource, and if patients don't want them at the end of the day, then there's no significant loss. There's also a couple of questions, a couple of comments about family members joining the rehab, which is incredible. A lot of nice comments about that. Obviously in pandemic times that is limited. Yeah. So when we think about COVID patients, it's especially when visiting is restricted, if not prohibited, then that is impossible, but a great point.
Yeah. Diaries. So we used to have paper diaries, and then obviously because of COVID we couldn't do that. So then I think we had some medical students that came to join us, and they set up our online diaries for us as well. Mm-hmm.
It's really nice, and some centres, not many, but the use of video diaries and obviously the use of digital technology now is really, really great, but it relies having, the time to do that, staff to have the time to do that. But look into the future, outside of pandemic, then there has to be something in that, doesn't there?
Yeah, absolutely. Yeah.
Well, you are bang on time. Thank you so much, Sam. Really appreciate it. Incredible presentation. Sam, again, very kindly has put her email and her Twitter handle on, so please reach out to her for any questions. And we will see you all at 3:30 for the final sessions of the day. You're nearly there. Go and get yourself a coffee, tea, water, gin and tonic if you fancy it.